Hello and welcome to your next episode where we talk to experts and interesting people about midlife or topics of interest to midlife. So, basically we just talk about whatever we fancy, don't we, Amy?
We do. We're very self-indulgent, aren't we?
That's fine. We've got no sponsors or anything, so we do what we like.
Oh, the freedom.
Yeah, the freedom.
The freedom of being unpopular, Louise.
Absolutely. So, anything you want to get off your chest, Amy, this week? Or,
at the risk of being courting Valium as our sponsors, I'm joking. We're on half term at the moment. So it is, we got up this morning, it's Monday morning when we're recording this, and the relief of
you haven't got a homeschool.
Not having to get the laptop out. It's been nice to do that.
I bet.
Yeah,
we can just sit around this week and do nothing and just watch films with them or something, can't you? Because it's cold out and
guilt free. I mean, will they have diabetes and no teeth by the end of the week?
Doesn't matter.
Yeah, exactly. I mean,
we're in a pandemic. It's unprecedented, so all of that is fine. It can all be sorted out further down the line, I reckon. So yeah.
Exactly. Yeah. How about you? How are you getting on?
Yeah, I'm fine. All I'm doing is watching telly, so I've got nothing else to talk about, I'm afraid.
That's today's art. I mean, people were talking about Picasso hundreds of years ago. Now we're talking about what are you binging?
Yeah, so I've binge watched. I mean, I'm a little bit late to it, really. It's a Sin, which everybody has been sort of raving about. Available to binge watch on All 4 at the moment. If you haven't heard about it, it's a drama written by Russell T Davies, and it's set from 1981 to 1991, which is when I was like a teenager. And it tells the story of a group of gay men and their friends in London living during the HIV/AIDS crisis. And now what I didn't know is that apparently, so I'm not going to give any spoilers away, but I just think everyone should watch it. I was like watching it going, oh God, isn't it terrible? The attitudes, and how far we've come on, and it wasn't even that long ago. I mean, it sounds a long time ago to much younger people, but what I didn't know was that apparently it was really difficult to sell to broadcasters because of its subject matter of HIV and AIDS. And the BBC One and ITV declined it. And Channel 4 only took it on after their commissioning editor of drama really fought for it. More fool them, BBC and ITV, because it's become Channel 4's biggest drama launch. And it's been watched by more than 6 million. It's been watched more than 6 million times and made it the most binged watched show to stream on All 4. But it was the subject matter was like they shied away from it, and that really surprised me.
Yeah, it's insane. It really is. It's funny because there's one of the guys that I know. He's probably in his early 50s. Oh, he'd slap me for saying that. He's a comedian, and he's a gay man who put on Facebook. Lots of people are asking me if I've watched It's a Sin. I don't want to live that again. Through that again. Thanks. I lived through it. It's going to take me a bit of. I need to sort of put a even a bit more distance between. Him genuinely losing people. But it's interesting because somebody was saying that Russell T Davies was being interviewed in a podcast, and he was saying obviously they did lose so many people, but obviously Russell T Davies, I guess is he in his 50s?
Yeah, I think he must be. Yeah. Oh, I think he's
obviously
lived
through it as well, and and has those stories to tell. But it is. It's a crime that so many people just lost their lives.
I mean, I can absolutely see why it's been such a hit. The acting, the writing, and the sort of depiction of what was going on at that time, and and you will fall in love with every character. It's joyful, but it's it is absolutely heartbreaking, and I can't remember the last time something affected me so much and stayed with me too. But I really can't recommend it highly enough. So
now, most people who listen to this will know that Louise and Paul, our producer, are married. Can I ask you a question?
Yeah.
Are you watching this together?
Yeah,
Louise?
we watched it together. Yeah, we watched it together. And with our, we've only got one child left at home, the youngest, who's almost 16. He watched it with us as well.
Ned was watching it as well. That is so good. I mean, for me, it's sort of like I have to put things into compartments. So what am I going to watch on my own? That would be RuPaul's Drag Race. anything to do with sort of frivolous stuff, because my husband Dan, he wants espionage, he wants intrigue, he wants sort of like he's watching 000 at the moment on Sky on Sky Atlantic, and I sort of took one look at the trailer and I said, I'm ever so sorry, this is not like, that wasn't made for me. So I'm thinking that there's a niche in the market for maybe, I don't know, like a political thriller with drag queens.
Oh, yeah.
Like the Venn diagram. We need to tick everyone's box. Or, I don't know, maybe I do need to sit in front of more, terrifying stuff, and he needs to sit. Maybe we need to blend our interests a bit more.
Yeah. No, we all really enjoyed it, and like my mum and dad watched it; they enjoyed it. My mum said that it made even my dad emotional, and and also my 20-something kids are watching it. Like everybody, I haven't met anybody who hasn't watched it and gone, "That was absolutely." Fantastic on every level.
It's hearing those stories, okay, and that's what gives us that compassion, isn't it? For and that's amazing. That's really
one to watch. Yes, definitely
one to watch. Today's guest is Dr Phillippa Kaye, and we've actually had her on before.
Yeah.
She's a GP and an author. You'll have seen her on TV, and she's this morning's doctor. Also, probably a highlight of her career.
Yeah.
When she came on the podcast, I actually listened to it today, Louise, because it was back last year, and for whatever reason, possibly I was crying into the back of the washing machine at that time, because it was sort of, we just locked down, and it was obviously one of those that I couldn't do. But she has the most wonderful voice and a real sort of clear, relatable nature.
Oh, yes, absolutely.
So the book she was talking about last time was The M Word, which is all about menopause. And today she's talking to us about her new book, Doctors Get Cancer Too. And it's her memoir of being a doctor and a patient with cancer. So she was diagnosed with bowel cancer in May 2019. And, half of us will receive a cancer diagnosis at some point in our lives and will immediately assume that death is imminent. And, the stats bear out that's simply not the case. The majority will recover, or if not, be able to live with cancer. And I guess we really need to change the story around, cancer diagnosis. And she does that so well, doesn't she?
She does, yeah. She's got a real skill for, obviously she's a doctor, she knows her stuff. She's very good at explaining, and her books, both her books are great, really, explain things really well and in an engaging way. And she's great. I follow her on Instagram, and as you say, she's on the TV, and she's got a real skill for, combining all of that together.
So have a listen to our chat with Dr Phillippa Kaye coming up next.
Thanks so much for coming on again. You were on before talking about your book, The M Word, if anyone hasn't listened to that episode. But this book, Doctors Get Cancer Too, is it's so personal and it's valuable in so many ways that we'll come on to. But can I just say right from the off, what stands out for me the most is the help that this is going to give people to feel less alone, because you really share very raw emotions and vulnerability. And I think that's what we all crave in challenging situations, isn't it? We need the comfort that comes with knowing we're not alone. And that can only come from someone who's going through the same thing. So, I just think it's a really valuable book, a valuable resource for people. So if I've got my numbers wrong, do say. But am I right in thinking bowel cancer is the fourth most common cancer in the UK? And I know in your book you refer to it as literally the shit cancer. So am I right in thinking that there is a real avoidance of acknowledging sort of like poo and farting and stuff in our society, and that isn't healthy, is it? In fact, it's probably dangerous.
Right. So you are completely right that bowel cancer is the fourth commonest cancer in the UK, but actually it's the second biggest killer. It's the second commonest cause of cancer death. And there are lots of different reasons for that. But one of them is to do with our natural reticence to talk about something something that everybody does every single day, and that is go to the toilet. Well, we might not go every single day, but everybody does it, and that's go to the toilet. And in other countries where the toilets are different and potentially there's a little shelf, that's there for you to look at your poo.
Is that what it was designed for that? Because I never knew that. Oh,
yep.
Okay.
Yep. And often, and I remember my kids, when we were allowed to go on holiday, my kids would go, why is that there? Why is the toilet so different? And that's one of the reasons.
Wow.
And just for the want of turning around or checking the paper, we are potentially missing things.
So what should we be looking for then?
So the commonest signs of bowel cancer now, if you have one of these signs, it doesn't mean that you have bowel cancer. It means that you have a symptom that needs to be checked out. Just like every breast lump needs to be checked out, but most of them are benign. So the first is blood in the poo. Now that can be bright red blood on the paper. It can be blood mixed with the stool. It can be blood in the water of the toilet. Or if your poo is black, and that can be that you're taking an iron supplement, but sometimes that's digested blood coming from higher up. A change in bowel habit. We all have a bowel habit, so it might be once a week, it might be 6 times a day, but knowing you're normal. And if that changes persistently for more than 3 weeks, and then persistent tummy pain for more than about 3 weeks. And if you have any of those, then it's time to see the GP.
Okay. And what symptoms did you have? That can we go back to sort of when and how you were first diagnosed? What led to that? Can you talk us through that? Yeah.
So the truth is that doctors are taught that when you hear hooves, don't look for zebras, look for horses. Common things are common. So I was not misdiagnosed, but none of us were looking for bowel cancer, because the risk in somebody my age at the time was 1 in 10,000. And I did not have those Bond or classical symptoms, blood in the poo, change in bowel habit, tummy pain. I had intermittent on and off pelvic pain, and I had a reason for it, in that I had 3 cesarean sections, I'd had my appendix out, I had an ectopic pregnancy, I had lots and lots of pelvic surgery. And when you have lots of surgery, you're more likely to have lots of scar tissue, and scar tissue can stick bits of your pelvis together or bits of your abdomen together, and that causes pain. And it was only as the pain got worse that I went to see the GP, who went, well, I'm also pretty sure that it's scar tissue, and went to see the gynecologist, who went, yeah, completely sure it's scar tissue, but your womb might be stuck to your bowel. You should go and see a bowel surgeon. And I remember being really irritated that I'd done a day of bowel prep, which is not very pleasant, and I'd taken a day off work, and that I was having a procedure where you have to be sedated for a colonoscopy, and I thought it was all going to be a waste of time, and I was going to end up having to have the scar resection surgery anyway. And so none of us were looking, and the surgeon went, this is going to be fine, we're just going to do this, and then we'll find the date and we'll book you in. And they pushed the sedation in, and I lay down, hugged my knees into my chest, looked at the screen, and saw something which was just clearly abnormal. And I turned my head, and the surgeon's eyes came up to meet mine, and even as I said, what's that, I knew. And as the room went quieter and quieter, and the nurses got kinder and kinder, and the more sort of professional chit-chat, pitter-patter happened, the more I knew, and the worse it got for me.
Right. And do you think you recognised when you looked at the screen and could see, like, would I have been able to see that? Or do you think that was because you knew what you were looking for?
It's difficult to know because I know what normal bowel looks like. But having spoken to other cancer patients, they often say that they are aware of a change in atmosphere in the room, or that they're aware that something was happening, or that something was a bit more painful, or that there was something. So it may be that some people sort of have an inkling, but I completely knew. And I felt my doctor wall go straight up. And all doctors have a wall, and sometimes people say, doctors are hard. It isn't that we're hard, it's just that if we give of ourselves always, if we give everything of ourselves, there is nothing left for us. And you can't function like that. So we have a wall, and that wall allows us to continue when things are tough, and then we go and cry in the toilets at the end of the ward round. But that allows us to jump up and down on someone's chest whilst you can hear their relatives crying, and you have to be able to continue. And I felt my wall go up, and the surgeon did all the things that we do when we are going to deliver bad news, in that, you go to a quiet room and you ask if somebody's going to be there, can someone else can be there with you, etc., etc. And I observed all of those things sort of happening almost outside my body in a very sort of, the doctor observed it all. And then the patient sort of just snapped and went, "It's cancer. Let's just call it cancer. Why are you skirting? Let's just call it cancer." And the surgeon went, "Yes, it's cancer." And I think it took a long time for that wall to come down.
Yeah. And did things happen very quickly then? You as I understand it from the book, you were sort of like, you were in hospital 10 days later, and it was all very quick.
Yeah. So cancer does move quickly, and depending on the urgency of what is needed, depends on the urgency of how quickly things are done. But yes, it moved extremely quickly. It was 8 days later that I was having major surgery. And in a way that is also why there was very little time to process. It was, I'm on this treadmill now, let's go. I'm on the roller coaster, let's go. And for me, that was a little bit easier, because once there was a plan, in fact, the whole way through, give me a plan, no matter how bad it is, and I'll get on board.
Right.
The waiting for the plan, the queuing for the roller coaster, is the bit that I find the hardest. So within, a week or so, I was in hospital for 10 days, in ICU for a period of time, then having part of my bowel removed. And then there was the recovery from that, followed by 6 months of chemotherapy. And then after that, before the pandemic, we hoped that I was done. And unfortunately, they found more growths on the scans, which they hoped that we could just monitor. But I ended up with 2 surgeries during the pandemic, one of which was an absolute whopper and a half that involved 10 days in ICU, 15 days in hospital on my own. And that was probably the hardest thing that I've ever done. But at the end of it, I was told in October that I am cancer-free. In the next 2 weeks, I have my first set of scans and scopes and investigations. And if you say to me, "Philippa, are you cancer-free?" I dutifully trot out, "Yes, I've been told I am." But I think until that first set is negative, I'm not sure, I believe. And because I've never had a negative yet.
No.
And once I have that, I hope that I will start to breathe again.
Yeah. Oh, yes.
Wow.
Yeah.
I mean, I think so many people will relate to that, what you've spoken about, I guess, having a plan and that being easier to follow, even if it is a terrible, it's not a pleasant plan, but it's a plan. You know where you are with that. I mean, do you think... It's interesting what you say. It's almost like a mixed blessing that you were a doctor, because you were able to almost look at it from outside of your own body.
So I think it worked, but it worked both ways, that there were advantages and disadvantages. So completely incorrectly, doctors somehow feel that their knowledge should protect their bodies. This is complete nonsense. But there is this idea that I should be able to be a super patient, that somehow my knowledge should make me heal faster or recover quicker or be better. None of that is true, but it does make you think that. But there are some advantages. I understand when you talk to me in medicalese, and actually that comforts me, because you and I are speaking the same language. I also know what there is to be scared of. And I am trained to always think about what comes next if this doesn't work.
Right.
So I'm always thinking ahead. So there have been times in ICU where I have sat in the bed and looked at my own heart trace and thought, "Oh, holy crap, somebody better come in." And I would be thinking about the drugs. I need this, I need that, I need t'other. And then the patient part of my brain would go, "I'm going to die now," and be utterly terrified. And those two things fought the entire way through. But just as it affected my ability to sort of be a patient, and the fact that I sort of battled with how much do I look after myself and how much do I rely on the team. Not that I never prescribed for myself. Doctors aren't allowed to do that. I never sort of doctored myself. But if you're on chemotherapy and you have a side effect, I think that most patients ring the specialist nurse. You ring the nursing team and you say, what should I take? And I knew what to take, and I knew what I could manage over the counter, and I knew what I could manage with the box of tricks that they send you home with, because they send you home with all kinds of drugs to deal with different side effects. And I think that I tried to cope for far too long. But how it affected me as a doctor, in that it has that there have been some real shifts in how I practice medicine.
Really?
And the main one of which is related to an event that I can pinpoint and I can take myself back to, and yet I don't know this doctor's surname. And it still amazes me that I don't know his surname, and he's changed my life. In that it was one of the very, very long nights in ICU when things were not going well. And the doctor came in and he sat down on my bed and he held my hand and he said, "You're having a really tough time, aren't you?" And he didn't try to fix it straight away.
Yeah, just
he
listened.
just acknowledged how awful it was.
Yeah.
And for just that 2 minutes, I didn't feel on my own. Because we can do tough things. We can. It's just easier to do them when we feel that we're not the only person in the room.
Yeah.
And so now, when my patients are having tough times, and as a GP, we understand our patients really quite holistically. We know where you live. That sounds really creepy, but sort of we know where you live and we know your family and we know your job and we know all about you. But actually, we're still trained to fix you. And even if that might just be with ourselves, come and see me next week, we'll talk about it again, or here's your sick note, or here's your prescription. But actually what I just do now is I wait and I say, that's really difficult, you're having a really tough time. And you see their eyes come up to meet yours and they take a breath.
Yeah.
And just for 1 minute, they don't feel so alone. And actually that's enough. It gives you the strength to carry on.
Yeah. Yeah. And,
Wow.
Going back to what I said at the beginning, I think that sort of, knowing you're not alone is, and that's why I think your book is so, going to be such a fantastic, just a comfort for people.
I'm sorry you had to go through that, Philippa, for your patients to have the most amazing GP experience. Maybe they should teach that. It's hard to teach that.
Do you know that what's interesting is that I didn't think about publishing this book for a really long time. It was for me alone. I sort of vomited my emotions out my fingertips to my laptop, which never went, you told me this last week. You're repeating yourself. Never did any of that. But when it was probably 6-9 months down the line that I began to think about whether or not this could help people. And what I thought about was the medical literature that we were told to read during some sort of optional module in medical school. And it was not medical literature written by medics for medics. They were sort of the memoir type books. And I remember thinking how we learn from our patients all the time. But that books were a way of living their experience and how valuable they were. And I thought that maybe that my experience could be valuable too. But the real other push to publish it was because so many of these diaries, and they are moving and wonderful, they end up with the person dead.
Yeah.
And then there's an afterword written by someone that loves them. And I, would snivel on the tube and wonder, why is no one saying what's wrong with you whilst, the tears are falling down your face? But actually, we have this idea that cancer is the beginning of the end. And for most of us, it isn't. And I really want that message to be out there that most of us are going to survive cancer. And even if we don't, we're going to be living with it for longer than ever. And we need to be sending out a message that cancer does not have to be the beginning of the end. And this is a book about survival and about hope.
Yeah, absolutely. You also talk about other people's reactions in your wider circle. And I'm just thinking, I would imagine that, again, this will be a good book for people to read who have a loved one or a friend, And I'm sure anyone that has had a cancer diagnosis would relate to the fact that sometimes people's behaviour can cause a burden in some way and also, hurt. What insight can you give for how to approach a loved one who's received a cancer diagnosis? What's going to be helpful for them, like emotionally or practically? How do we make sure that even when we have the best intentions, we're not adding to a burden for that person?
So the book is definitely not just aimed at people with cancer. No. It's aimed at people who know someone with cancer, and quite frankly, that's all of us. Because it's really difficult to separate our own emotions from somebody else's. And so I was very aware and felt guilty, even though it wasn't my fault, it was my cancer's fault. But very aware how much I was hurting people and how when I hurt, they hurt. And that's called transference. So, when you're with someone that's very sad and a tear creeps out, or when your partner's really angry and you feel yourself getting angry too, you're picking up on some of their emotions, and that's called the transference. And what you feel when your best friend or your partner or your mum is in pain, that tiny bit of pain that you feel is unbearable. And so you try and fix it. Which is what we come back to. You try and fix it. And you say, it's only 3 more chemos to go. You're doing so well. You're strong. You're superwoman. You've got this. I don't feel like it. And if you don't let me say that, if you can't acknowledge that, then I begin to think that my feeling isn't valid.
Right, yeah.
And then I feel guilty about that. And I think, well, what am I supposed to do with that? But I do feel that I don't feel strong today. And I feel sad and I feel angry and I don't want to go to chemo and I don't want to be positive because being positive makes no bloody difference at all. And I want to be able to express that to you. So I would say to anybody who has a friend going through it, first of all, if they want to talk about it, you need to be able to listen.
Right.
And that's quite a task.
Like that doctor did for you, listening without trying to fix things. Yeah.
They're not asking you to make it better. They're asking you to listen. But if they don't want to talk about it, remember that they were a person before cancer. And I was a person that liked, shoes or gossip or cocktails or whatever it was. And maybe I still want to do those things. In fact, I definitely still want to do those things because I want to remember that person still exists and that I'm not just completely overtaken by cancer. Yeah. So to try and remember them as the person that they were and that they still are, because I think that's really helpful. And then the last thing is something really practical. Don't give me choices, give me answers. So when you say, the world is very different to how it was 50 years ago. 50 years ago, you probably turned up on my doorstep with a meal or something. And that would have been that. Now you send me a WhatsApp. Let me know when it's a good time to come over.
Yeah.
I don't know. I don't know, because some days it took me an hour to get out of bed. And some days I then spent the next 3 hours in the toilet. I don't know. Let me know how I can help. I don't know. Yeah. I don't know what I need. I've got no headspace for me to tell you what to
figure that out for you.
What I need, right, is for you to work it out. And for you to work it out in a way that means that I don't need to ask you for help, because that's hard.
Yeah.
And we're having to do that in so many ways. So what would help me is when you're in Tesco, say, and buy the milk, do you need some? I'm passing your door on the way home. To say, I'm coming round at Wednesday at 11 o'clock for a cup of coffee. And if at 5 to 11 you say you don't feel well, don't worry about it. I'm going to get on with the rest of my day. You can ring me 5 minutes before. Yeah. The very practical things, as opposed to making me choose. You choose for me.
Yeah.
That I found helpful.
Yeah.
And if your friend's got young kids, offer to do the school run. That's always the answer. Offer to do the school run.
Yeah,
that's an easy one with young kids, isn't it? When you're saying that, I've been guilty of doing that sort of, let me know when's good to come up, because I don't want to force myself upon somebody who is in a situation. But actually what you're doing is just adding another bloody thing. Yes. They need to, it's just another thing on their list of things to do, isn't it? Oh, I've got to text Amy and let her know what time.
And things to think about. Whilst if you say to me, so we're Jewish, so I'm going to use Friday night dinner as example. If you say to me, I'm roasting you a chicken for Friday night, okay, I don't have to do that job.
Yeah.
That's easy, not would you like me to? And what would you like me to cook?
No,
I don't know.
No. Just do it. Yes, just do it.
Yeah.
And I see that. And also that, what you said about just remembering who that person is, completely separate from the cancer, because they're still that person, aren't they?
Yeah.
So we hear quite a lot about, being brave and soldiering on and you got this. And I guess there's a strength in surrendering, but taking time to recuperate is something that lots of us, I guess, will feel guilty about. I mean, did you find that, or was it just, it was non-negotiable, you had to rest and you were going to do that?
No, I was awful at that. I think there's two questions in there. The first is about sort of what I call toxic positivity. People would send me emojis of biceps or Supergirl's cape. I didn't feel super.
No.
I never felt super. I never felt brave. I never felt strong, ever. I felt stoic. I felt determined and fed up and angry a lot and sad a lot. And I didn't feel positive. I felt determined. And they're actually quite different things. So when you told me all the time how strong I felt, again, I didn't feel listened to. And you don't have to be positive. You just have to keep going. And that's where you show your strength. And it took me a long time to realize that bravery or courage is not going in and running into the battlefield saying, I'm going to do whatever it takes. Bravery is running into the battlefield knowing it's going to hurt. And so every time you go and it's going to hurt, having the courage to go anyway. But you can go kicking and screaming. You don't have to go in skipping. That's the first thing. And the second thing is as a society, we are rubbish at convalescence. We used to be brilliant at it. Have an operation, go down to the seaside for 2 months to a convalescent home. And now there's this idea that the moment you leave hospital, you're cured. You're not. And it took a long time for recovery to not feel selfish. And it was only that I was ill enough to be forced into it, I think, that I began to understand that. And then the recovery of your mind takes an awful lot longer than the physical recovery of your body, and a lot of therapy. And I have been very open that I have been to therapy since a couple of months after my diagnosis, and I still go to therapy now because cancer is a huge, huge trauma. But it is difficult to then get the balance between recovery and listening to your body, but pushing your body to heal. So you have to get up, get out of bed day one of this major surgery where they have cut you from just underneath your breastbone all the way down to your pubis. You get up on day one. And on day two, you take 3 steps to the chair. And every day you have to push through. And you have to balance that against recovery. And for me, the balance was never in the physical work that I knew that I had to do, but was the importance of going to work. So yes, I had to take 6 to 8 weeks off after each of my major surgeries. But as soon as I was able to go back to work, even though work was utterly exhausting, was hugely important because for my recovery mentally, because it made me remember that I existed and that I wasn't only a cancer patient recovering or a cancer patient waiting for chemo. And so actually the balance of the two things, the balance of what you need to recover your body and what you need to recover your mind, and they might be conflicting sometimes, but that's something that needs to be worked on.
Just going back to what you were saying before about, I think your book and your Instagram account, because also you've documented a lot of this on your Instagram account when you were in hospital back in, was it September, October?
Yeah, September and October. Yeah.
And also your TV appearances, your book, your IG account, your TV appearances are really valuable because I think sort of fluffy suggestions around self-care just aren't helpful, and you don't do that, but you kind of address the feelings around it, which I think is very valuable.
I think that if all there is left for you to do self-care wise is a bubble bath, I'm really jealous of you. I know that sounds really, really not nice. But I'm really jealous that your life is so good. That that's the only thing left to do, right? Because for me, self-care starts with, are your basic needs as a human being met? And that means, are you warm? Are you fed? Are you dry? Do you have a place to stay at night? Are you taking your medicines? Are you looking after your body? And then, are you healthy sort of physically? And then we move on to our other needs. And then we can get to the bubble baths.
Yes.
And it was a long time before I was at bubble bath. Yeah. In fact, I'm not even sure I'm at bubble bath now. But self-care. So self-care, I think it means lots of different things to different people. But if you are telling me, and my patients say, I want to take the time for myself to have a manicure, and I say, but you're not taking your antidepressants.
Yeah.
Your manicure is not going to solve that.
No.
And I think that we need to be pushing self-care, because what essentially self-care is being able to love yourself enough to look after yourself. And that needs to come from the inside before we do the superficial things. And I'm not putting down a bubble bath. I love a bath as much as anybody else. But are you whole from the inside first?
Yeah.
You were saying before that in 2 weeks' time, there's this line in the sand, isn't there? You were talking before that you kind of, you feel like you should say you are cancer-free, technically, but you're waiting for that next screen in 2 weeks. Is that right?
Yes, that's right. And all cancer patients and cancer survivors live scan to scan. And what we call scanxiety, so anxiety around your scans, is really real. But I am also very aware with my doctor's hat that one can't just rely on the scan, because if you rely just on the scan to believe, then what's going to stop me wanting a scan at 5 months instead of 6, or at 3 months, or at 2 weeks, or can I have blood tests next week and this week to reassure me? And so you can't just rely on that. But the first set is a really big set. And then I guess I spent a lot of time when I was in the middle of my treatment talking about wanting to get back to normal. And it took me a very long time to understand that there was no getting back to normal, that I have to accept that cancer is something that's happened to me and that it's going to always be part of my life now. And so it's that dreadful word, the new normal. And I am going to have to find my way within that. And for me, that will be beginning to plan, because that's something that cancer patients don't do, is that you don't plan too far ahead, because that's too frightening. And I guess in some way, the pandemic has taught us all not to plan, because who knows what the rules are going to be next weekend or in 2 months' time. So we've all learnt to live in the present. But what's helped me the most when it comes to scanxiety, even though when I've gone between sort of positive scan to positive scan, and it was all a case of, let's see how much this has grown and what we're going to have to do and what we're not going to have to do, is to shrink time. So when 6 months or a month or 2 weeks right now is too much, to shrink time further down. And we all do this. So you've got a big meeting at work, you're going to have a very difficult day. So you reward yourself with, I'm going to have that nice bubble bath at the end of the day, or a nice meal, or a bar of chocolate, right? And so we shrink time. And then we shrink it even further. Well, I've got an exam. It's just an hour and a half. You have to get through the hour and a half. And sometimes we shrink time to the next 5 minutes, because I can get through the next 5 minutes. And in hospital, there were times when I was not even at the next minute. I was at the next breath. But shrinking time to make yourself in the present, as opposed to thinking about the future, can be very helpful.
Wow. Oh, wow. That's such, wise words and insight. And can I ask you, what is going on with screening at the moment? Because is it offered from over 60 at the moment, but it's supposed to be dropped to 50 or something? But
so for bowel cancer, currently the screening program starts at 60. A couple of years ago, it was agreed that the screening age would be dropped to 50, because that's when the incidence of bowel cancer begins to rise quite significantly. And the government agreed they would do that, but they didn't put a start date to it. And so nothing has been fixed as yet. And as frustrating as it is, and now of course there's been a pandemic on top of that. Currently the screening starts at 60, but if you have any of those symptoms before you go in, and if you happen to know that you have a family history, if you know that your dad passed away of colon cancer at 45, don't wait for symptoms, go to your GP, because there are screening that we have a way of getting you in. If you have a very strong positive family history, we can refer you for screening colonoscopies earlier.
Right. And if somebody who did have that family history, how often would they be screened? I'm just thinking about what you were saying just now about how you could almost become addicted to that and just want to be sort of scanned every 5 minutes. But how often would that happen for that person?
It depends on what the family history is, and whether or not we know what your gene is and what we see on your scan. So, for example, there is a condition where you have lots and lots and lots of polyps in the bowel, and then you would have regular colonoscopies, and sometimes it might be annually and sometimes it might be 5 yearly. As it so happens, I was found to have a gene that doubles my risk of bowel cancer. Now, it doubles my risk from 1 in 10,000 at the time to 2 in 10,000. So it was still pretty rare at my age. But what that means, though, is that when my kids are 16, they will have a choice as to whether or not to be tested. And my siblings now have had that choice. If they are tested and they are negative, then they're the same as everybody else in the screening program. If they test and they're positive, then probably every 5 years from the age of 30 that they would have a screening colonoscopy.
Right, okay.
That's amazing, isn't it? I guess, like you were saying before, we have to get with this with the knowledge that we will all be living with cancer for longer as we look into the future, over the next 3 or 4 decades.
Yeah, but when it comes to bowel cancer, the vast majority of bowel cancers grow from benign polyps. So if you have a screening colonoscopy because you've got a family history and a polyp is found, the polyps are removed during that colonoscopy.
Right.
And therefore you don't get cancer.
Yeah.
And so you can pick something up and you can prevent it even happening.
Yeah.
Incredible, isn't it? Wow. Thank you so much for taking the time to talk with us, Phillippa, and sharing your experience so articulately and your knowledge. And obviously the book, we'll put all the links in the episode to that, and also your Instagram account. I'm sure you're inundated daily with messages of gratitude there. Thank you for chatting to us.
Thank you for having me.
A podcast from producerpaul.co.uk.